Okay, so we'll go ahead and get started for this evening. Thank you everyone for joining us to this virtual second annual conference for the National Hispanic Pharmacists Association. I'm going to hand it over to Ben Milana, who's going to give us a little bit of housekeeping items.
Thank you, Dr. Rivas. Hi, this is Ben Milano from the National Hispanic Pharmacists Association. Just a few housekeeping items. Everyone is currently on mute, but if you accidentally unmute yourself, please keep your, please make sure that you're muted. Additionally, you will see a chat box. If you have any questions, we will have a moderated question and answer at the end of all of the presentations. So please use the chat box to send your questions to me. Other than that, I will turn it back to Dr. Rivas. Thank you.
Thank you, Ben, and everyone at the National Hispanic Health Foundation for all of your assistance in today. First off, I'd like to acknowledge everyone in which we're going through this COVID-19 situation. Thank you for your flexibility and thank you for joining us today. We were flexible enough to be able to make this happen. So to start off, I'll go ahead and give a brief welcome, and then we're going to dive right into ambulatory care for Latinos with diabetes by Dr. Cauthon. And then we'll move on to approaches to managing hyperglycemia in diabetes, in patients with diabetes and hospitalized patients by Dr. Francisco Ibarra. And then we'll move on to community pharmacy care for Latinos with diabetes by Dr. Bettis towards the end. And then we'll have a moderated Q&A. Next slide, please. All right, so our mission here at NHPA is to empower Hispanic pharmacists and other members to improve the health of Hispanic populations in collaboration with public and private sector partners. Our vision is to be the lead pharmacy organization for improving the health of Hispanic populations in the United States. Next slide, please. And here we have our board of directors, all of the board members, including our CEO and secretary and treasurer. Thank you so much to everyone for helping make today happen. Next slide, please. So what we do, NHPA serves as a resource to federal government organizations to partner on how to improve pharmacy policies and programs for the Latino community. NHPA develops membership for individuals to improve pharmacy services for Latinos, and NHPA also supports and mentors pharmacy students going through pharmacy school through the NHPA chapters. Next slide, please. So for our NHPA activities, we have been very busy this year. So in terms of programs, the annual conference, and today with cultural competency in Latino patients. Also videos from the first conference and with the board member interviews. And then we will have this as a standing continuing education on diabetes in Latinos for pharmacists. And we've also brought more student chapters on board. And we are committed to supporting our pharmacy students through scholarships for outstanding members who are serving the Latino community. In terms of development, our corporate partners are Walmart, CVS, and Pharma. We also have institutional membership with pharmacy schools. And then we also have our Hispanic Heritage, which is Fall 2020 event with our sponsors in Southern California, San Antonio, and other regions. And to donate, please visit the website listed here. In terms of membership, we're currently at nearing 200, ranging from pharmacy students to licensed pharmacists and associates. And then for membership benefits, we offer a variety of networking with like-minded pharmacists, mentoring the next generation of pharmacists, Latino health education for pharmacists, and also leadership development for other pharmacists who are interested in Hispanic communities. Next slide, please. So we'd like to acknowledge everyone, every single one of our corporate sponsors. So thank you very much to everyone for helping today happen. Next slide, please. And so here are different ways that you can all connect with us. Please follow us through our multiple ways of social media. And if you have any questions, you can feel free to email us or call us. All right, so here is going to be the information in order to get credit for this CE. I do believe that there was an email that was sent out, but more to come at the very end. And if you do have any questions, please feel free to email us or let us know at the very end. Next slide, please. Okay, so I'm going to hand it over to Dr. Kimberly Cowtham. Thank you so much for presenting today.
Thank you so much for having me. And I thank all my students and the dean who are on here as well. We have a new chapter of NHPA at our school at University of the Incarnate Word. I am a pharmacist at the South Texas VA and at the University of the Incarnate Word, and I'm going to talk today about my ambulatory care practice at the South Texas VA. Ben, next slide, please. My outline for today is to talk a little bit about my practice and how I perform ambulatory care, and then to focus on what evidence is out there about the efficacy and safety of diabetes medications in Latino and Hispanic patients, and to talk about strategies around that for improving diabetes medication adherence, but improving the quality of life and diabetes care for these patients. Next slide, please, Ben. This is a snapshot of the community in which I live. I live in San Antonio and in Bexar County, and the majority of residents are Hispanic or Latino. Then I practice at the VA, where right now there's 20.5% incidence of diabetes and higher than that in the Hispanic diabetes population. And I don't have the exact numbers for South Texas, but this gives you an idea of where I work in ambulatory care. Diabetes, type 2 diabetes, is the biggest need. Next slide, please, Ben. My practice is to see patients for individual appointments. The patients are referred by their primary care provider. They can be referred by themselves, although that's not as likely to happen. They're referred by the certified diabetes nurse educator to see me or any of the other pharmacists at the VA for an in-person telephone or video conferencing appointment. So we offer multiple ways for the patients to have access to see us. And each appointment takes about 20 to 30 minutes, depending on their needs. But the majority of the patients I see is for type 2 diabetes, because that's the biggest need here in San Antonio. And I have students with me and residents with me most of the time throughout the year. And the big stress point during this rotation is that the biggest priority is taking care of this patient and making sure that the patient feels welcome and that they are the most important thing, the most important person in that appointment during that time. At the VA, I have access to a lot of other services to refer the patient, whether it's to diabetes education, the dietitian. We have health coaches. We have MOVE programs that help set goals for patients to exercise more, eat better. And so these are all the things that are available to the patients that I see if they want to take advantage of them. And during this appointment, we perform the medication history, and then we determine what medications we can change. We can counsel the patients. And so my job most of the time is adjusting or working with the patients to adjust their medications. Next slide, please, Ben. What I keep in mind during these appointments is some of the literature that has been surveyed about patients with diabetes and their medication-related concerns. And specifically in Hispanic or Latino patients, it has been shown that they worry more about side effects, have concerns about becoming dependent on the medication, and potentially unwilling to take more medications when recommended by the provider. So I keep this in mind with all the patients I see, and thinking about discussing the side effects with them and weighing the benefits and the cons and talking with them about the course of the diabetes diagnosis. Next slide, please, Ben. The rest of my presentation will focus on strategies to improve A1C and quality of life, really looking at medication adherence. And number one, I put pharmacists. There's a new study in the Journal of American Pharmacists Association looking at pharmacists and the impact they make in patients with diabetes, specifically Hispanic patients. And so definitely pharmacists make the difference. And just to reemphasize that about ourselves. But also to look at how the American Diabetes Association, their standards of care is based on the patient-centered approach. Look at what studies have been done in the Hispanic and Latino population for the medications, and then to share with you some decision-making aids that can be used in any setting that you're practicing in, and always focusing on that communication technique of the teach back and the shared decision-making. Next slide, please, Ben. This is a very busy slide, but this is the American Diabetes Association standards of care on what they recommend as treatment for patients with type 2 diabetes. And you can see that there are a lot of different columns to go down, or a lot of different choices to make. And they're really dependent on what are the other disease states of that patient. If your big concern is hypoglycemia for the patient, if you're more worried about weight gain for the patient, or cost is a concern. But nowhere on this slide do you see about ethnicity, or it's not like the hypertension guidelines that specifically recommend certain medications for Black patients. So when thinking about what medications to give, we'll also think about what are the genetics and what is the pathophysiology of diabetes. So Ben, the next slide. This is the ominous octet, or the current pathophysiology for diabetes, type 2 diabetes, and where the different medications are targeted. There is also recently the egregious 11, which they've added an altered microbiome, immunosuppression from diabetes, and inflammation as other potential targets for medications in the future. But I've circled here in terms of what has been the research in Hispanic patients. And there has been research that insulin resistance is more common in the Hispanic or Latino population, and that leads to more insulin production and over time decreased insulin secretion. And so some of the thought is, well, should we be targeting those medications more, or those medications that will alleviate those problems? There has been some evidence, although not as strong, as which why I didn't circle it, but that there is an increase in the gastric tract, and so there might be the GLP-1s or the DPP-4 drugs might be more efficacious in this population, but that's not proven. Next slide, please, Ben. The first study I'd like to present to you is a systematic review of just medications studied in the Hispanic and Latino patients, just asking what is the evidence for these patients. So when you're seeing them, this Hispanic or Latino patient, have these drugs been studied in the patients we're seeing, or in the population we're seeing? And so these are the older medications, the metformin, sulfonylureas, pioglitazone. And this study really tried to look at what were the clinical endpoints, but their conclusion were that Hispanic patients are not well represented in clinical trials and didn't really find a difference for the Hispanic patient. Ben, the next slide. And then this is my summary of some of the post-hoc medication trial data in Hispanic and Latino populations and some of the newer classes of the diabetes medications. So you can see for some of the GLP-1s, while not a majority, in the post-hoc analyses where they separated out Hispanic patients, there was a good number, or a good percentage to be able to talk to your patients about. And but again, these studies are from the drug approval studies. They're after the fact. They weren't powered to specifically for Hispanic patients, and they're not being studied. Most of the time, they're not being studied against comparator drugs. So in terms of GLP-1s, those are listed first for the dulaglutide, exenatide weekly, and liraglutide. The similarities are they were shown to be as efficacious, meaning there was no statistical difference between the non-Latino or Hispanic patient, and there were no increased risk of side effects either. For the SGLT2 inhibitors, the only data I could find was for canagliflozin, and again, similar efficacy. For the DPP-4s, the ones that I was able to find were sitagliptin and linagliptin, again, similar efficacy. And then there's also the newer studies with the newer insulins. And while there was similar efficacy, there was a statistical difference in terms of the amount of insulin needed in the Latino and Hispanic patients. And this could be because of that they have more insulin resistance than some other patients. And so while it was statistically significant, I'm not sure how clinically significant it was, as in general, it was in one study, for example, the basal insulin glargine or NPH, it was that non-Hispanic patients needed 0.6 units per kilogram versus 0.7 units per kilogram in the Latino or Hispanic patient. Next slide, please. So with that information, it's just being able to tell patients who want to say like, oh, I'm a guinea pig, or oh, I have some concerns, or has this been studied for me, that there have been studies in Hispanic or Latino patients, and really the efficacy has shown to be the same. And then, so really when we're looking at the ethnicity, there's not really a difference right now shown in terms of the different options, say as like with hypertension. But one of the other things that I sometimes use that you can use online or paper cards is the Mayo Clinic has a shared decision-making tool where you can prioritize what the patient thinks is their biggest concern. And I like this one too because it includes daily blood sugar testing, as that's sometimes a big concern from the patient, or that's something that they want to do less of and want to be safe. But these are just some of the cards. There's also ones about weight gain or weight loss and hypoglycemia. And it is available in English and Spanish, plus some other disease states. Next slide, Ben. These are my CE questions, and they highlight patients, and we'll go over the answers, and they highlight patients or a combination of patients I've seen over the course of my time at the VA. So a lot of times I see patients are referred to me when they have pretty high A1Cs. Generally, they're referred to the pharmacist after that time, or where the primary care provider believes they need more intensive follow-up. So this example is a 58-year-old patient, and you can see he's on 5 injections per day. His refill histories are not up to date, but again, he's on 5 injections per day, which is not easy for anyone, and he's on metformin, and his A1C is really unchanged and high over time. And so these are the patients I get referred. And so just starting the appointment, just asking what they think is the cause of their high A1C, what are their concerns about their diabetes, what are those things that they want to change. So sometimes the first appointment is just to gather more information, or sometimes the patient really divulges. And so this is kind of a combination of different things I've heard from patients over the years, is that yes, it's difficult to adhere to the schedule of these 5 different injections. And then I'll be told I only use the Novolog when the blood sugar is high. But then when I look at their glucometer, I don't see that they've really checked their blood sugar. So then I say, so there were 5 times. And so really they're not giving their Novolog. And then the patient also has concerns of more weight gain. They've seen their weight increase with the insulin. And then when they do give all their medicine in one given day, you see the hypoglycemia as well. So the first question is, which initial intervention will decrease the risk of hypoglycemia the most? As generally that's the first in terms of their medication therapy. We want to prevent the hypoglycemia, but also address the patient's concerns. So my approach here is to listen to what the patient says, what they will be willing to do, and try to simplify the regimen. So the correct answer here is A, discontinue the Novolog and change to metformin once a day, because they're not likely to be giving that Lantus twice a day, and it might have been titrated up to be too high of a dose anyway, without them really taking it. And then continue metformin because it has those long-standing benefits. I think sometimes I do gather more information, like in the other example, in the other choices, but this patient seems to be screaming out they really want it simplified, so that's what I try to do. And then trying just to get them to check their blood sugar, whatever we agree together is reasonable for them, but without them being on Novolog, we don't have to worry about the hypoglycemia as much, and they don't have to check their blood sugar as often. Next slide, Ben. So this is the same case and kind of following up with the patient, in that which medication could be the best choice for this patient based on his A1C and frequency of administration. And so if he's really concerned about the schedule, but also really needs a 3% decrease in his A1C overall, and based on the information that we have about these use in Hispanic patients, I would pick D here, dulaglutide, because the GLP-1 is going to have the most A1C lowering after compared to these other agents. And also it's once a week. So the patients generally really appreciate that, and they pick their day of the week that they want to give that. And again, this is when cost is not a concern, which at the VA, we have a formulary. Dulaglutide is on the formulary, so it is an option for us. And as long as the patient doesn't have any contraindications, such as gastroparesis or history of pancreatitis, this is an option that might be much more effective for this patient and his weight gain concerns and helping with weight loss versus the Novolog and the potential the unsafety of that with him not checking so often. So this is just an example of the ambulatory care practice that I have. So I'm done, and I look forward to learning from the next presentations. Thank you, Ben.
Great, thank you so much. And up next, we have Dr. Francisco Ibarra, who's going to be presenting on the inpatient aspects of it. He's an assistant clinical professor at UCSF School of Pharmacy. Welcome, Francisco.
Thank you for the introduction, Dr. Rita. My name is Francisco Ibarra, and I'm an emergency medicine clinical pharmacist at Community Regional Medical Center of Fresno, California, essentially within the Central Valley of California. We've often been described as the armpit of California, but we're a little bit more than that. We are a tertiary care center affiliated with the University of California, San Francisco. We manage a diverse population with Hispanic and Latinos comprising nearly 50% of the patients we treat. Next slide, please. Today, I will be discussing evidence-based approaches to achieving and sustaining euglycemia in patients while hospitalized and after discharge. We will first begin by reviewing the management of hyperglycemic emergencies, as these events are a significant cause of morbidity and mortality in the Hispanic population. Later on, we will be discussing the management of non-critically ill patients, reviewing recommended therapies, and blood glucose goals. And lastly, we will touch base on strategies to increase adherence and prevent readmissions. Next slide, please. The incidence of diabetic ketoacidosis, or DKA, how I'll refer to it throughout the rest of this presentation, is nearly 50%, with higher rates observed in patients with type 1 diabetes. However, within the Hispanic community, this pattern is not observed. Hispanic patients with type 1 diabetes are just as likely as those with type 2 diabetes to present with DKA. Furthermore, Hispanic patients with undiagnosed diabetes are just as likely to present with DKA as type 1 and type 2 diabetics, a finding indicative of Hispanics' lack of access to appropriate health care. Next slide, please. This is incredibly concerning because newly diagnosed uncontrolled hyperglycemia is associated with a 16% in-hospital mortality rate, with advanced disease progression being a driving cause. Given this high in-hospital mortality, it is imperative that we as healthcare providers manage these patients appropriately. Next slide, please. Two common hyperglycemic emergencies encountered in the emergency department include DKA and hyperglycemic hyperosmolar syndrome, which I will be referring to as HHS throughout this presentation. Although there are similarities in the diagnosis and pathophysiology of these two disease states, it is important to recognize that differences do exist between these two disease states. DKA results from absolute insulin deficiency, whereas HHS results from a relative insulin deficiency. Type 1 diabetics are more likely to present with DKA than type 2 diabetics, whereas type 2 diabetics are more likely to present with HHS than type 1 diabetics. Although the overall mortality of type 1 diabetes is low, it is the most common cause of death in children and adolescents with type 1 diabetes. DKA accounts for half of all deaths in diabetics less than 24 years of age. On the other hand, HHS does occur less frequently than DKA, but it does carry a higher mortality rate with ranges upwards of 50%. DKA is characterized by significant ketoacidosis, and an anion gap metabolic acidosis. Now, in DKA, keto acids dissociate in blood and circulate in the anionic form, binding to free bicarb, thereby leading to a reduction in bicarb and leading to an elevated anion gap. Patients with HHS tend to be more hyperglycemic than patients with DKA and present with hyperosmolality. Excess blood glucose levels lead to significant fluid shifts, osmotic diuresis, and severe dehydration, characteristics of HHS. Next slide, please. Several nomograms and protocols exist for managing hyperglycemic emergencies and are often institutional specific. Therefore, I will not be reviewing the specifics of managing hyperglycemic emergencies, but will rather be reviewing some of the management principles. In both the management of DKA and HHS, patients should receive crystalloids to restore intravascular volume. The patient's corrected sodium levels should be used to direct selection of either half NS or normal saline. Since both diseases result from a loss or reduction of insulin, insulin should be administered. Now, insulin can be administered either subcutaneously, but that should be reserved for non-severe cases, whereas it can also be given as a continuous IV infusion, which should be reserved for critically ill patients, as the infusion has a faster onset of action. It allows for easier titration and better achievement of glycemic. Electrolytes should also be repleted as needed to normal values. Now, it is important that potassium levels are within the normal range prior to initiating insulin therapy, as insulin can exacerbate hypokalemia by causing an intracellular shift of potassium. Hypokalemia should be appropriately managed, as it can lead to fatal arrhythmias. While the management of the two disease states is quite similar, their goals of care do differ. In DKA, therapy is directed at resolving acidosis, whereas in HHS, therapy is directed at resolving hyperosmolality and altered mental status. Next slide, please. Now, a few points to keep in mind is that in the management of DKA, euglycemia is achieved before acidosis is resolved. The mean time to decrease blood glucose levels is 6 hours, whereas the resolution of ketoacidosis can take up to 12 hours or more. Once the patient's blood glucose levels begin to normalize, it is important to start dextrose to allow for continued administration of insulin so as to prevent hypoglycemia. In the management of HHS, is it important to not lower blood glucose levels too quickly, as this may lead to cerebral edema. Due to the increase in extracellular osmolality, the brain increases its osmolality largely through gaining unidentified solutes to protect itself against changes in volume. Now, if the blood glucose were to drop too quickly, these brain solutes will draw fluid in and cause cerebral edema. Avoiding rapid correction of blood glucose will allow the brain to lose these gained osmoles and prevent cerebral edema. Next slide, please. Aside from treating hyperglycemic emergencies, inpatient goals of care include the safe regulation of blood glucose levels, as well as avoiding hypoglycemia, as these can lead to worse patient outcomes. Should also be used to direct initiating long-term anti-diabetic treatments in patients not already on therapy and who should be on therapy, as well as to optimize existing anti-diabetic treatments. Now, this can be accomplished by increasing or decreasing current doses or adding on additional agents. Next slide, please. The American Diabetes Association has issued blood glucose goal recommendations, which are specific to the patient setting and disease severity. In the outpatient setting, premeal blood glucose levels should be within the range of 70 to 130, and postprandial blood glucose levels should be less than 180. In the inpatient setting, non-critically ill patients' glucose levels should be within the range of 140 to 180. Most critically ill patients' blood glucose levels should also be within this range, but consideration can be given to targeting lower glucose levels in cardiac surgery patients and patients who are admitted to the neurocritical care units, as studies have shown these populations to benefit from lower blood glucose goals. However, this should only be done as long as the benefits of tighter blood glucose control outweigh the risks of hypoglycemia. Now, as previously discussed, in the management of hyperglycemic emergencies, the initial blood glucose goal should be less than 200 and 300 for DKA and HHS respectively. Once the patient is no longer in an emergency, their blood glucose level should be within the range of 140 to 180. Next slide, please. Regarding the pharmacological management of hospitalized diabetic patients, insulin is preferred to the use of oral anti-diabetic medications, even if the patient is insulin naive. This recommendation is based on the fact that there's limited data out there to support oral agent safety and efficacy in the inpatient setting. It is important to note, though, that oral agents can be continued in select patients, but these patients need to be stable and have an expected stay of less than 3 days, and this is done to avoid disruptions in care and better prepare the patient for discharge. Regarding insulin administration, sub-Q administration is recommended in most patients, whereas IV infusions are recommended in critically ill patients, since infusions can be easily titrated and they do result in better glycemic control. Next page, please. Now, when initiating insulin in-house, it is recommended to administer basal insulin opposed to just sliding scale. As shown on this slide, the use of basal insulin resulted in more patients achieving euglycemia as compared to those initiated on a sliding scale. An additional benefit of basal administration is that it's less frequent injections. Next slide, please. Now, the last component of managing inpatients is to address post-discharge issues while the patient is still admitted. A huge contributor to readmissions in Hispanics is medication non-adherence. Medication non-compliance is influenced by many factors, including cultural beliefs, financial hardships, and language barriers. Studies have shown that the less English a Latino knows, the more likely they are to be non-adherent. This issue can be mitigated by assigning these patients to a Spanish-speaking provider. Several studies have proven that Latinos with no to limited English assigned to a Spanish-speaking provider have higher adherence rates and lower A1Cs than those who do not have a Spanish-speaking provider. This finding is incredibly powerful as it emphasizes the need to have more Spanish-speaking providers serving our communities. Next slide, please. Another strategy to mitigate readmissions in the Hispanic population is to include the family in the patient's care. Families are an integral part of Hispanics' lives, and involving them will lead to improved patient outcomes, as demonstrated in studies that have shown the benefit of an 8-week course involving patients and their families. And lastly, we as providers need to empower our patients to take an active role in their health. This last point can be accomplished in many ways. Most recently, I was able to accomplish this by discovering what motivated my patient. Now, I had a patient who presented to the ED at least every month for DKA. He was a classic frequent flyer. Every time I spoke with him, he gave me the impression that this was the time that he was going to take control of the diabetes. He swore by it. He was no longer playing around. He was going to follow his regimen accordingly. However, he continued to present to my ED. When he presented a few weeks ago, I was reviewing his home med list, and I saw that he had a new medication on his list. It was a medication for erectile dysfunction. I asked him when he started taking the medication, and he told me he has been struggling now for some time to perform at his best. It was at that moment I realized this was my opportunity to open his eyes to see the severity of his decisions. I explained to him that it is very common for male patients with uncontrolled diabetes to suffer from erectile dysfunction. I explained to him that if we were able to get his diabetes under control, he may no longer need to take a pill for assistance. His eyes opened up so wide after hearing this. It was definitely a sight to see. It has actually been now more than a month since I've last seen him, which is the longest time that has passed since I first met him. Now, this specific approach may not be applicable to all patients, but the point I want to emphasize here is that you should never give up on your patients. We all made an oath as providers to ensure that we're an advocate for our patients and providing them with an optimal level of care. So we need to continuously be there for the patients, even when they're not there for themselves. And lastly, you need to find out what motivates the patients to take control of their lives, because if you can do that, you'll make better decisions. They'll make better decisions for themselves. Next slide, please. That concludes my presentation. Thank you, everybody.
Excellent. Thank you so much, Dr. Ibarra. Now we have Cynthia Perez, a pharmacist from Walmart. Welcome, Dr. Perez. We look forward to the presentation.
Good evening, and thank you for having me. My name is Cynthia Perez, and I will be discussing caring for the Latino patient with type 2 diabetes as a community pharmacist. Next slide, please. Our objective today will be to identify how the community pharmacist captures the attention and increases the trust of Latino patients with diabetes in the community pharmacy setting. And we're also going to explain how the community pharmacist addresses barriers of Latino patients with diabetes. Next slide, please. I practice in the community pharmacy setting, which is located in El Paso, Texas. Because of geography and the fluidity of our borders, I have the privilege to care for Latino patients that live in the United States, both in Texas and New Mexico, and patients that travel across the border from Mexico into the United States. I also have many patients that live in the US and cross the international border to Mexico for affordable health care. In terms of demographics, El Paso is 83% Latino, and about 10% of the community has diabetes according to the CDC. Next slide, please. In the traditional community pharmacy practice model, patients get a pharmacist consult when they are prescribed a new medication or there has been some change to their medication dose or directions. In our model, we counsel patients that are not only new to therapy, but may have gaps in therapy, may need to get up to date on their vaccinations, or may be non-adherent to their medications. During these initial conversations, we try to capture enough attention from the patients to increase their trust. Pharmacists or interns review each patient profile holistically and try to find gaps in therapy, and usually this is due to medication non-adherence. The amount of time to counsel in the retail or community setting is very short. So initially, we may choose to discuss one piece of the overall medication therapy. The initial approach may be as simple as having the patient explain back to us how they take their medication. Upon our next visit, the conversation might be around whether they remember to take their medication or perhaps why they don't take their medication. In this way, the conversations at consult are layered and longitudinal, and any noteworthy information from each conversation is documented so that at each subsequent counseling session, we'll have a different approach based on the last visit. And we also partner with a local community diabetes organization that takes new patients we refer, and the diabetes organization also refers patients back to us. We're able to see the patients in the pharmacy, but I'm also able to see the patients at the diabetes organization meetings as well. Additionally, patients are always invited back to the pharmacy for longer clinical visits than the initial counseling encounter. Next slide, please. When the patients return to the pharmacy, the first approach we take is to meet each patient where the patient is at and try to understand barriers they may have to understanding diabetes or their medications. The patients may have barriers that are top of mind to the patient, and until these are addressed, the patients may many times will continue to be non-adherent to their medications, which is usually the main issue we encounter in the community pharmacy. For many patients, these barriers are what are known as the social determinants of health. According to the World Health Organization, the social determinants of health are the conditions in which people are born, grow, work, live, and age, and are the wider set of forces and systems shaping the conditions of daily life. There are patient-centric barriers that affect positive outcomes that can be very large, complex problems, which can be overcome with specific interventions to engage patients. Healthy People 2020 has also created social determinants of health that can be barriers to patients, and there's literature to support that these are major barriers to care and should be used to determine a strategy by healthcare providers. This is the first approach we take to capture the attention of patients and increase trust, and many times allows us to break through as healthcare providers. In our community, there are many social determinants of health, and the complexity of caring for these patients can be rooted in one or several of these. Next slide, please. Economic stability is the first social determinant of health that we typically try to understand from the patient's perspective. Patients may come from a low-income household or possibly have the insecurity of not knowing when one might have a job. One patient may be the head of household for their family, but they may also take care of extended family members. And grandparents may also be the caretakers for grandchildren, which means they are also financially responsible for the children's well-being. Determining this for us is critical, especially when we consider why a patient is non-adherent to medications. If their routine is complex, we try to find a way to make it simpler. This might include supplying a calendar or a pill box that the patient may use as a reminder tool. Patients we serve may use public transportation as well, and may not always have the means to get to our pharmacy. We try to find out if we're able to switch them possibly to a 90-day supply so that they minimize the trips into the pharmacy. If they're also not able to afford their medication, we try to contact the provider for a cost-saving alternative. We try to work with their providers. We also can use our retail formulary, which includes $4 generic, to help get them medications that align with their budget. We try to find a way to remove the economic barrier for the patient if we can. Education is also extremely important from a health literacy perspective. We try to ask questions to determine the patient's understanding. Does that patient have the ability to read an amber vial label and also understand the information on the bottle? We try to find out what the patient's primary language is. Will the patient interpret the English directions correctly? And would motivational interviewing work with a patient? Motivational interviewing allows us to use open-ended questions to understand the patient, but sometimes for some patients, it may come across as too invasive. We try to tailor that conversation to the patient to ensure that this does not happen. A patient may also present with cultural beliefs that impact their understanding of diabetes or their medications. For example, some patients we've come across believe that this is the fate that their God gave them, and we try to ensure that the patients understand how to take a proactive approach with their therapy and disease state management. And culturally, many patients also believe and depend on alternative medicine. When patients are allowed to discuss their medications, as well as supplements such as aloe vera juice, then we can build a rapport and relationship because they know that they will not be judged for any beliefs or use of herbal remedies. And health and healthcare is also a very large component as well. Patients may get their healthcare here in El Paso, where the average wait time is about 6 months to see a physician, or they might cross the border into Juarez, Mexico for a doctor, dental, or eye visit, where the visit can cost as little as $1 to $2. On average, patients in the United States see a PCP 3.5 times a year, but may see a pharmacist up to 35 times per year. For many that cross the border into Mexico to see a doctor or have to wait a long time to see a provider in El Paso, which is medically underserved, that may mean only one visit per year to their doctor for that patient. We try to determine how we can fill the gaps for the patients that may not see their doctor for some time and answer questions or guide them in between those critical visits. Aside from determining what kind of healthcare the patient has, we also try to determine what health benefits the patient is on. And we try to determine how we can create an out-of-pocket cost reduction for the patient. For patients, for example, with Medicaid, that might entail us having to order a specific manufacturer or NDC for that patient, and ensuring that it's always in stock so that our patients remain adherent to their medications. Or patients may also be using herbal remedies or homemade recipes to help control their sugars. In this case, we try to determine what alternative therapies they may be on. And while many prefer herbal remedies to medications and trust that they will work just as well, we try to educate patients on the importance of why they need to continue on the medications they have been prescribed. Neighborhood and built environment is also important as we get to know our patients and increase trust. We want to know where they live. Do they cross the border? What does their neighborhood look like? And from a social and community context, we like to know also what is the family dynamic like. In my instance, within my community, families are very tight-knit. You may have a family household that consists of grandparents, adults, and grandchildren. Do the grandparents care for the grandchildren? Do adults have grandparents living with them and taking care of them? And if so, are we able to engage family members to help support that patient on their journey? As community pharmacists, we're extremely accessible, and the ability to understand these barriers for any patient is usually the first approach we take in our pharmacy practice model to really try to capture the trust and attention of our patients. Once a patient knows that I understand what the barrier for them might be, I'm able to create a rapport and start a relationship with a patient. If I do not start trying to gain trust with them with regards to understanding their barriers, then many times the patient will never trust why I'm trying to get them to take a medication or assist them with their medication management. Next slide, please. As mentioned previously, the demographic of our population is very diverse, but the ability to capture the attention of the Latino patient has to start with whether there exists a social determinant of health or a barrier to their understanding and managing of the disease state. Once we determine what barriers exist, it's easier to capture the attention of those patients, and that can be a longitudinal approach over the course of several interactions as mentioned earlier. We build relationships with patients when they are invited back to the pharmacy for a longer clinical visit with a pharmacist or intern. We also empower our technicians to practice at the top of their license by training technicians to know how to complete basic screening, such as blood glucose, cholesterol, BMI, and blood pressure screenings. These are completed free of charge for the patient and build stronger relationships with the total team. Technicians and pharmacists also review new diabetic supplies the patients may have received but may not understand, and this can include a new glucose machine, the strips, or the lancet. Patients return to the pharmacy to gain better understanding of how to use their supplies. This occurs frequently as many of our patients are predominantly Spanish-speaking and do not understand or cannot read the manual that comes with their monitors. Team members are trained to be able to walk through a patient if they don't know how to use a machine. Technicians have helped us identify barriers for patients many times during a clinical visit with a patient and the pharmacist. As an example of a most recent intervention, we discovered a patient receiving erroneous results on their machine. This occurred because a patient thought the blood glucose strips went in the refrigerator along with their insulin. However, the patient thought the results that were erroneous, thought the erroneous results were from the medication and that the medication was not working and was planning on discontinuing the medication. The patient came back to our pharmacy, learned how to use their machine, discovered that glucose strips are stored at room temperature, and also received new strips after the technician spoke with insurance and manufacturer. In this capacity, our technicians play a vital role in capturing the trust of our patients. Within our community model, we have also been able to forge relationships with community partners such as the local diabetes organization. Pharmacists, technicians, and interns attend their meetings and answer questions for patients or complete a show and tell with devices. From working on the bench in the community pharmacy to the partnership with the diabetes organization, we have been able to create a collaboration with the physicians, nurses, dietitians, and podiatrists that also work for the patients. We have been there to lead patient support groups and discuss topics such as copays, insurance, deductibles, recommended vaccines, and alternative medicine. The diabetes organization also refers patients back to our pharmacy so that they can begin to foster a relationship with a pharmacist as they begin their health journey. In this capacity, we're able to create relationships with patients in and outside of our pharmacy, and this has also allowed us to increase the trust we have with the patients. Overall, total pharmacy team engagement allows us to capture the attention and increase trust of our patients. We work with patients to help move through any barriers that may exist, support a model that allows for longitudinal patient counseling as well as follow-up visits, and we have also partnered with a local organization to create a continuum of care. Next slide, please. And so this was one of my questions for CE. The social determinants of health are conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. Which of the following is a social determinant of public health as defined by Healthy People 2020? And that would be social and community context. Medication adherence or medication non-adherence are definitely very important. That's the reason why we see a lot of our patients, but the answer would be social and community context. Next slide, please. And technicians are vital in fostering an environment of trust and can be empowered to complete basic screening for patients. True or false? So hopefully everyone answered true. And that completes my presentation.
Wonderful. Thank you so much to everyone, Dr. Pauthon, Dr. Ibarra, and Dr. Perez. It was very informative. I actually took quite a bit of notes. So to start off the Q&A, I want to invite everyone who was able to join us today, go ahead and think of your questions, and then we're gonna unmute you, and we would ask if you could raise your hand. In order to find the section to raise your hand, you would have to, at the very bottom middle, click on participants. And once you're able to see everybody's name at the very bottom right-hand corner, there's a little box that says raise hand, and then go ahead and raise your hand, and then Ben will unmute you. But while all of you are thinking about your question, a general question that I have for all of our speakers for today, so first off, I'm very excited about this for today because it's at least the first time that I'm actually participating and observing the continuum of diabetes care from the inpatient to the AM care to the community setting. So a question for all of the speakers today, is there something that, is there a piece of advice or a clinical pearl that you'd like to share with the rest of your fellow pharmacists, whether they're in the AmCare setting, inpatient community pharmacy, that you wish they would know or do, or a piece of advice that you feel would be crucial in order to help your patient go through the inpatient, ambulatory, and then community setting? If anyone has any thoughts, feel free to jump in.
Hi, this is Kim. I think I'd just like to share again the importance, going along with the community pharmacy setting, is the importance of, no matter how long somebody's had diabetes, that doesn't mean that they're using their insulin correctly. And so always having them show you back how they're using their insulin pen or their insulin needle and device. As again and again, I see patients over a long time, even if they used it a long time, they're doing it incorrectly. Just things like, you've told them to, increase from 40 to 50 units, and just turns out really they've been using 4 units and going to 5 units, and that's why it's not been working. So I think that's something that no matter what setting you're in, you can always look at and help the patient with.
Thank you. Any thoughts from Dr. Perez or Dr. Ibarra?
This is Dr. Ibarra. The point I will make is the same one I made during the presentation, is just to really emphasize the need to really empower patients so they can make the decisions for their own and really understand the severity of their disease state, but also not to give up on these patients, even if they are your frequent flyer, the individual who's repeatedly coming back for the same issues. Continuously be strong for that individual and find out what motivates them to take better control of their health.
Thank you. All right. Dr. Perez, any thoughts?
Thank you so much for having me. I learned a lot. I definitely agree that we can't give up on our patients. I think for anyone that is in community pharmacy, we really do try to engage our patients. And I think, it's time is a limiting factor, but if we can truly make that amount of time that we have with that patient and really try to make a connection to understand what their barriers are, even if it just means to open up that conversation for a later time, if they can't, speak that at that point in time, or they don't have the time. I think from a community pharmacist standpoint, there's a lot of impact that can be made. And while we may have time limitations, even a couple of minutes while you interact with that patient can go a long way. And that's what's gotten some of our patients to come back and try to have longer, visits with us at a later time. So don't underestimate the power of having that conversation with that patient and really trying to engage them.
Wonderful. Thank you, Dr. Perez, for that wonderful insight. It looks like we have a question here. Do any of the locations use the 340B federal program? And what experience do you have with that?
This is Cynthia Perez. I do not have any experience with 340B. I work in a retail setting.
Yvonne, I'll go ahead and briefly answer your question. Okay. Let's see here. So when I worked at a federally qualified health center, I did work with the 340B program. I know that the number one thing for the 340B program is to make sure that you have a compliance officer and making sure that all of the rules and regulations are being followed. And then auditing is very important. There's also a 340B conference to attend. It's an utmost valuable thing to have and to offer to patients. And Yvonne, I believe you are on mute. Do you want to ask any further questions about the 340B program?
Actually, that wasn't my question, but thank you for answering. I just wanted to add one of the doctors had mentioned that a lot of the patients don't, a lot of Latino patients don't participate in the clinical trials. So I just wanted to say it's a good thing that she pointed that out, because it's important for us to encourage them to participate, because we need to let them know that they're not being treated as guinea pigs or anything like that. We need to get rid of that misconception, but it's mostly because their data does matter. And if they can participate, it'll help us make better decisions for the Latino population. That's it.
Great, thank you, Yvonne. And I do want to correct that question about the 340B program was from Carlos Martinez. Carlos Martinez, do you have any additional questions about the 340B program?
I don't actually. I was just wondering if the clinics or the practicing spots were using it. Just my only question.
Great, thank you. All right, any additional? Okay, I think those are all the questions that we have for today. Any last thoughts, questions from anyone? We have about a minute or two.
I guess I do have one more question, actually. Yvonne, kind of adding off of Yvonne's statement, do these clinical trials need to have like some kind of citizenship part or anything like that? Or do one of the requirements they have to be a citizen to be able to do these trials? Granted, I know not every Hispanic or Latino is undocumented, but could that be a reason why they might not be going to the clinical trials?
No, so actually that is something that a lot of patients think, that they need to be legal residents or citizens, so they get scared. But I actually work at a clinical trial site, and a lot of the patients are Latino, undocumented, and I tell them, don't worry about that. That's nothing that plays into this. So if you're undocumented, you can definitely participate. I clarify that.
Oh, thank you very much.
Mm-hmm.
I want to say thank you to all the speakers.
Yeah, thank you very much.
Okay, looks like we'll just take one last question. This is for Dr. Perez. In regards to the referrals and collaborative care you provide to patients at the pharmacy and at the diabetes clinic, what kind of payment or reimbursement plan is in process? Is there a formal CPA? That's the question.
There is no formal reimbursement. Basically, when we have patients that are new to therapy or have ongoing therapy, but really are looking for support groups or a dietitian or physician-supported groups, we refer them and we give them all the information. And we go and speak, it's free of charge. We interact with all the patients there, and we have different, topics to discuss. And it's usually a panel where we either discuss, speak on a topic to everyone, or we have breakout sessions. And so then the patients, when I see them back in the community setting, they might let me know about their most recent visit or most recent interaction. So it's been a really, really great interaction, a really great collaboration. We also participate in their diabetes walk every year. So we get to see some of those patients that make it out. So there's no reimbursement. I really just truly do it because of how much diabetes hits home to me. So it's been something that I've been involved with for a long time.
Wonderful. Thank you for the question and thank you for the answer, Dr. Perez. Again, I want to thank everyone for your flexibility today. I hope that everyone is staying safe at home, and if you have to shelter in, and even if you're in the front lines, thank you so much. And please, everyone, stay safe. In terms of earning the CE credit, an email will be sent to you, and a recording of the webinar will be available at the NHPA website if you'd like to share this with other colleagues who were unable to join us today. And this CE will be available for a year in order to receive CE. So once again, thank you very much for everyone. Please stay safe, and please keep all of your loved ones safe as well. Thank you so much.
Thank you.